now invite Dr. Purendra Bhasin, who will be talking about Toric IOLs, an elegant way to control astigmatism. And he'll also be covering Dr. Saurabh Chaudhary's talk on intraoperative image-guided systems. Dr. Purendra Bhasin is again a cataract and refractive surgeon, a very high-volume surgeon from a leading practitioner from Gwalior, and is also a very well-known figure in AIOS and all international meetings. Over to you, Dr. Purendra.
Thank you, Dr. Ashu, for including me in this course. And I will be sharing my experience of using Toric IOLs in last almost 18 or odd years, and this is definitely an elegant way to control the astigmatism. And this is a Japanese studies which tell us that even a 0.5 diopters of astigmatism, the number 2 graph, which shows that it decreases the vision substantially. So, and with 1 diopter and 1.5 diopters, the vision comes down further. And this is with the brief introduction. And astigmatism correction with Toric IOL improve visual outcomes. It's a better visual acuity. It provides less post-operative refractive astigmatism, high ratings for clarity of vision, greater spectacle independence for distance, high patient satisfaction with Toric IOLs, and these are the comments which are out of these various studies which has been done. So the scope of this present presentation is on, we will be discussing on pre-operative assessment, intraoperative pearls, and post-operative surprises if we have any, and how to correct them. The points to ponder are, we should understand the patient's expectations, and because many patients, they now want a refractive correction and they want the best vision. Why do they require glasses for distance and near both? But for the distance, they are very much concerned now, and proper counseling is has to be given. Careful patient examination should be done, and we should find out whether it's truly a corneal astigmatism or some other corneal irregularity is there. And if we find that there is a epithelial basement dystrophy, then we should treat it further, and then we should go and plan for the cataract surgery. Similarly, if there is ocular surface disease, Meibomian gland disorder, before taking the patient for surgery, we should manage them before, and look for the corneal dystrophy, presence of Salzmann nodule, because the Salzmann nodule produces a very high astigmatism, even in the range of 3, 4, 5, 6 diopters, and presence of any scars, whether central, paracentral or peripheral, and look for the RK, PRK or LASIK, which has been done in the to the patient. Coming to the patient selection, accurate preoperative testing of the cylindrical power and axis is very, very important. We have to treat only corneal astigmatism. Mind out, many times we see that the patient comes to us and for the refractive correction, and we see, and there is a cylindrical acceptance, and we see there is a subluxation of the lens, or there is a lenticonus anterior or posterior. So we have to look, thorough slit lamp examination is done. Toric IOL is recommended in a case of preoperative corneal astigmatism of more than or equal to 1 diopter. This is my routine practice. In multifocal IOL cases, I choose to correct even less than 1 diopter, that is up to, even if it is 0.75 diopters, that improves the quality of vision to the patient. A potential candidate for Toric IOL would have regular symmetrical corneal astigmatism. Patients with irregular astigmatism will not improve with Toric IOL. It may worsen if there is a high irregularity. There are 3 steps for Toric IOL implantation. First is accurate preoperative testing of cylindrical power and axis, marking the axis on the eye both pre and intraoperatively by either digital or manual method, and intraoperative alignment of the IOL into the desired axis. So we will be discussing all 3, and if there is an error in any one of the step, this will lead to the poor visual outcome and poor results on the patient. Coming to the step 1, which is the preoperative planning, which is useful for all the ways to correct the astigmatism, whether it is LRI, whether it is OCCI, or whether any other method. So we should perform keratometry after, and by manual or automated keratometer, and make sure that there is a corneal astigmatism. There should not be a dryness, and perform topography. This is also mandatory. The location of this will tell us the location of the steep meridian or axis, if the astigmatism is regular, whether the astigmatism is symmetrical, and any ectasias that will also be informed to us. Perform a posterior corneal measurement with the help of sham plug imaging systems like Pentacam or Galilei if they are present, and I also do ASOCT in all these cases, which tells us about the dry eye and other things. Use magnitude of astigmatism of manual or automated keratometry and recheck by IOL master or lens star or any topographer. So this is very, very important. There should not be a variation of more than 10 to 15 degrees between these two. Compare with the axis derived from topography or Pentacam. So these three are to be done in all these cases. Before moving ahead, we must confirm it with multiple measurements. Mind it, all these things should be done on a nascent cornea, means we should have not used any topical mydriatic agent or topical lubricants in these eye, because they are going to affect the outcome and astigmatism meridian as well as the power of astigmatism. So we should do it on a nascent eye where nothing has been applied to the eye. Before moving ahead, we must confirm it with multiple measurements. When results from two instruments do not agree at the axis and magnitude of astigmatism, we should postpone it. We should ask the patient to come again, and if reading from manual keratometry and Pentacam, which is topographer, are not within 10 degree, then we should repeat both after calling the patient again, or we should ask the patient to wait for some time. For 1 to 1.25 diopters of with the rule astigmatism, we may use on-axis incisions, as has been discussed by Dr. Ashu, rather than a toric IOL. Coming to the aspect of posterior corneal curvature. We all by now must be aware of that the posterior cornea is a vertical steep in about 87% of the eyes. This is the study which tells us, and it causes a net against the rule astigmatism. As this is a concave lens or a minus lens, it causes an opposite effect. So therefore, because it causes an against the rule astigmatism, so therefore there is a slight undercorrection with the rule astigmatism, and a fully or slightly overcorrection we have to do undercorrection in the with the rule astigmatism, and we have to do full correction of slight 0.12 or 0.20 diopters of overcorrection in the against the rule astigmatism. The ideal one should be when we have a Pentacam or Galilei sham plug system, then we should look for the exact posterior the corneal curvature, and we should use it exactly. So another important aspect is the surgically induced astigmatism. All of us has a different surgically induced astigmatism. It varies, as Dr. Ashu has already said, it varies from where the location is, what is the size of the incision, and what is the length of the incision. It varies from patient also looking to the cornea's brittleness and turgidity, and there is a measurement variability also. So this should be measured, and we should send the data and calculate it of our 25, 50 or 100 or 500 cases, maximum number of cases with same number, same size of keratome which we are using, same technique, same incisions, paracentesis incisions also, and same type of IOL if we are using, then we send it and we can calculate our surgically induced astigmatism. I started when I used to do it earlier with 2.8 millimeter incision, then it used to be 0.35, now it is 0.11 in my cases. So this is very, very important, because this will give us the exact power which has to be implanted, and otherwise we will have a residual refractive error in the form of cylindrical power. Then coming to the what IOL formula we should use, and various studies have said that the Barrett's Toric IOL calculator formula is the best and superior amongst all, and we all are using the same formula now. Coming to the marking, pre-operative marking. This is the way I do it when I do it manually. I ask the patient to sit on a slit lamp, forehead touching to the band. The head is kept vertical. It should not be tilted or it should not be slanted. And with the free hand, because this is a Hawkstride type of slit lamp, which can when we can make the axis of our slit vertical or horizontal, we can use it. And in a 90-degree meridian, with this slit of the lamp, we can by free hand we can mark it with the marker pen on the at the limbus, and similarly by rotating it on a horizontal meridian we can mark it, and 3 marks are sufficient: 0, 90 degree and 180 degree. And this is marking which we used to do within the operation theatre by the bubble marker. And there is a bubble here which should be within these 2 lines. This is the kind of mark which we get, and this is the patient sitting on the operation table, and there itself you make the patient lie down, and then you do it under topical or peribulbar anesthesia. That is your choice. So this is how the pre-operative marking is done, and this is how it looks here after the slit lamp marking which we have done. Other markers are also available, electronic pre-operative marker, that is their choice, but I think the cost effective is the slit lamp marking system, and this is how we align the marking system intraoperatively. This is the pre-operative marks which we have made, and there is slight misalignment, and then we can further align it, refine it. This is sometimes you get all these things, so you have to refine it. This is 0, 180 degree. I am sitting on a temporal side, and then we have to, as we have to implant the lens at 167 degree, so we can intraoperatively mark 167 degree, and then the lens will be aligned with this 167 degree. The lens should be placed short of the implanting axis to be intended axis to be implanted, and this is the lens which is aligned to the 167 degree mark, and this is how it is done, and a perfect capsular axis and immaculate surgery should be done. So then coming to the digital marking system, the most popular are the from Alcon Varion, and the other one is from the Zeiss Callisto. Intraoperatively, there are 7 pearls. Corneal marking should be done appropriately as we have demonstrated. Capsular axis size should be adequate. It should completely surround the lens surface, and there should be a 0.5 to 1 millimeter overlapping. Position IOL short of intended axis of implantation as we have demonstrated. OVD removal under the IOL is very, very important. Don't leave any viscoelastic substance behind the IOL, otherwise the IOL will rotate in the immediate post-operative period, or the power of the IOL will be different and you will have a refractive error in the post-operative period. So for that, after removal, tap the IOL to fixate to the capsular bag. These IOLs are hydrophobic IOLs. Because of the tackiness, they adhere to the capsule, posterior capsule, and that is what is mandatory and required. Don't overfill the chamber. That is also very, very important, because if we overfill the chamber, the fluid percolates behind the IOL in the bag, and it may rotate in the immediate post-operative period. The final IOP should be in low mid-teens. That you have to check by pressing the sclera or the tip of the cornea, apex of the cornea. Final check of the lens position is done at the end, as we have demonstrated in the first case. So this is how the lens, we have to send the data or we have to fill the data to the software, and the axis here was at 94 degree, and the cylindrical power preoperative at the corneal meridian was plus 3.22, and then the company IOL for the IOL workup, we have sent it the data, we have calculated it online. The 25 diopter lens has to be implanted, a T6 model from the Alcon company, no financial interest. The residual refractive error will be 0.16 in this particular case, which has been shown. So SN T6 model, 25 diopters, cylindrical power 3.75 diopter correction at 95 degree we have to use. So this is with the digital marking system or variant system. After the capsular axis, polishing of the lens bag, we implant the lens in the bag, and hydro implantation is useful in all these cases if you are comfortable with. But in all my toric IOLs, I use hydro implantation, and the lens is now aligned short of the intended axis. As you can see here, I am removing all the viscoelastic from which is present in the cartridge while injecting the lens into the bag, and then I am rotating it with my bimanual system, or you can do it with the help of a spatula or a Sensky hook, and this is perfectly aligned, as you can see here, with the intended axis. So another case. So when we do without the variant system, definitely we find out that there is some misalignment because of the smudging, and there is some advantage over the when we do it with the variant system, but not much. If you don't have, you can do a manual marking also. The top consideration in success of toric IOL prediction is we should use topographer, use keratometer, biometer to calculate power difference between the principal meridians, include posterior corneal astigmatism. You should optimize your surgically induced astigmatism. Consider whether overcorrection to with the rule is warranted for patients with ATR and oblique astigmatism. Try no visco IOL implantation for better results. Coming to the second part, that is the residual astigmatism. Sometimes we come across with it, and this could be due to the incorrect IOL power. There is a role of posterior corneal curvature. There is a discordance in cylindrical axis, as we have discussed, enumerated before, between various instruments. And surgery didn't go your way, like poor creation of incision. Your blade was blunt, and you have early entry is done, and sometimes there are unexplained reasons. So what we can do is we should understand the residual refractive error and whether it is spherical, cylindrical or spherocylindrical. And in most of these cases, when there is a misalignment, you get a mixed astigmatism with when the plus spherical or a minus cylinder, or the minus spherical or plus cylinder. So IOL axis on slit lamp should be checked after dilatation of the pupil, and placement of IOL tilt, or whether one haptic is in the bag or other haptic is in the sulcus, that should be checked. In this particular case, we have planned for a 23 diopters toric IOL implantation. Intended axis was 160 degree, as you can see, and everything went fine. This is a plate haptic lens, and we have placed the lens at 160 degree. I am sitting temporally, and this is perfectly aligned at 160 degree. So this is the end of the surgery. But after a week, the patient came to us with a 624 uncorrected visual acuity, which was 6.6 or 6.9 on day 1. So best corrected vision with plus 0.5 diopters of sphere and minus 2.5 diopters of cylindrical was there. Patient was improving. We saw that the IOL was rotated. The IOL we implanted, the axis was 160 degree at this meridian, but now it is at around 90 degree and as we are sitting temporarily. So what we did, we just released the adhesions of the anterior capsule with the lens with the help of spatula, make the lens free, and we should wait for at least a week or two before rotating, and if you don't find any other reason, and then align it again. This is how we did, and later on the patient went well. So this could be otherwise done with the this website, that is astigmatismfix.com, and wherein we enter the residual refractive error and what we have to do, where we have to implant our new axis of the IOL, that will be given to us, whether we have to rotate it or explant it or exchange it. Other options are, we can use excimer laser system, or as Dr. Bharti has very nicely elaborated on the LRI, we can do it. To conclude, toric IOL for 1 diopter and above against the rule astigmatism, we should plan. With 1 to 1.25 diopter of with the rule astigmatism, one can use on axis, because we have to undercorrect. We have to use on axis or paired incision, opposite clear corneal incisions, as Dr. Ashu was telling, that we can do. Intrastromal LRI arcuate by femtosecond laser is another good option for less than 1 diopter of astigmatism, as there is a less dry eye, wound gap and better predictability. Adding toric IOL to your surgical armamentarium is a must now in this present era, and my almost 25% of the practice or 30% of the practice is of toric IOL. Thank you for your patient hearing.